Okay, good afternoon, everyone, and welcome to our next session, Generation Genome. One of the major challenges facing those affected by rare disease has been getting a timely and accurate diagnosis. Genomic technology has offered a step change in our ability to diagnose genetic conditions and discover new rare disease genes. Back at our 2015 summit, Dr. Richard Scott of Genomics England came and outlined the vision of the 100,000 Genomes project. So in this session, we're going to be looking back at the progress that's been made over the last 5 years through that project and the launch of the NHS Genomic Medicine Service, and thinking forward to the challenges that the implementation of this genomic technology presents going forwards. So with that, it's my absolute pleasure to introduce Dr. Richard Scott, the Clinical Director of Genomics England, Dr. Sarah Bowdin, Medical Director of the East Genomic Laboratory Hub, Sasha Henriques, the Principal Genetic Counsellor at Guy's and St Thomas's, and Rebecca Middleton, the Vice Chair of the Participant Panel at Genomics England. So get involved and add your comments and questions in the chat or Q&A, and over to you, Richard.
Thank you, Gemma, and thanks everyone for joining us. It's great to be here virtually. As Gemma said, I joined the summit back in 2015, actually when I very recently joined Genomics England, and it felt like a very different place we were in terms of sort of understanding what the future was in terms of rare disease, knowing what we could achieve and what the real challenges were. And we thought it'd be really nice to spend some time this afternoon reflecting back on that, but also really spending some time thinking about the areas we need to focus on more now that we have a bit of a clearer view of where we are today. So I've been introduced. I work at Genomics England and I'm the clinical director there. By background, I'm a clinical geneticist, so I also work at Great Ormond Street, seeing children with rare diseases to diagnose them. And the team I've got with me here on the panel today, I think will give us a really nice broad perspective as we go through those conversations. Before, we're going to start by reflecting a bit on the 100,000 Genomes project itself, but I wonder whether it would be nice to start with just hearing a bit from each of the panelists about who they are and where their perspective is coming from, so we can and then we can get into the meat of our discussion. So perhaps if I come to first to you, Rebecca.
Thanks, Richard. So I'm Rebecca. I'm the Vice Chair of the Participant Panel. I joined as a founding member back in 2016. I'm a rare disease patient and I was diagnosed as a rare disease patient as an adult. So came to the 100,000 Genome Project newly diagnosed and have been through the journey of the 100,000 Genomes Project as a patient and as a representative on the panel too.
Thank you. Sasha, should we come to you next?
Hi, I'm a genetic counsellor. So I've been a genetic counsellor in Manchester, South Africa and London. So I am really interested in how we practice genetic counselling for people from all different cultures and communities. And I worked in cardiac genetics for a long time as well.
Thank you. And Sarah?
Thanks. I'm Sarah Bowdin. I'm the medical director of one of the genomic laboratory hubs, of which there are 7 now in the UK, in England. And we work as a network, so we're the ones who are commissioned to provide the genetic tests for any clinicians who are requesting them for their patients. My background is in clinical genetics. My first love, I suppose, is paediatric clinical genetics. And the reason that I really wanted to do the GLH medical director job was because for many years I spent, in clinical genetics being frustrated at the lack of ability to be able to order tests. And from the 100,000 Genomes project, clearly one of the main outcomes of that was that so I think we could discuss that as one of the points, but the bottom line is it's a brilliant opportunity now to be a GLH medical director to actually get that into clinical practice. So that's why I'm hopefully on the panel today.
Thank you, and thanks to all three of you for joining us. And hopefully we have a nice sort of broad range of different backgrounds and views in terms of our discussion. So what we thought we'd do is start by talking a bit about the 100,000 Genomes project, to sort of think about what the journey there was like, where that has taken us. So just as a sort of a reminder to people who are sort of less familiar with it, the 100,000 Genome Project was first conceived in 2012, and it was a government-funded program. And we, Genomics England, were set up as we're slightly unusual in being a government-owned company to deliver the project in partnership with the NHS. And really the aim was to use whole genome sequencing for the benefit of patients who are receiving care in the NHS, and with the two major areas of focus being in rare disease and in cancer, and to embed that the project, which was done under a research consent in the NHS, but very much link clinical care with research. And over the 5 years of the sort of the recruitment phase of the project, a total of 35,000 rare disease families were recruited, about 17,000 rare disease participants. So it was a real clear signal, both from the rare disease community about how ready and enthusiastic they were to embrace whole genome sequencing, but also a really clear expression of the need, which I don't think at the beginning of the project people knew. At the very beginning, there was an expectation of probably at maximum half of the participants being rare disease participants, perhaps lower. So in many ways, that was a sort of a real clear signal. And I think one of the key pieces of evidence that then was useful for the NHS in terms of thinking about what the next stage would be, and Sarah's mentioned, and we'll talk about this a little bit later, but really planning the genomic medicine service and how that might take on some of the learnings and even some of the infrastructure that was built for the 100,000 Genomes project. And there's been lots of successes, but I think one of the really sobering figures across the whole of the 100,000 Genomes project is that the overall diagnosis rate for participants across the rare disease program was a little over 20%. So that means nearly 80% of people didn't receive a diagnosis through the program. That obviously varies a lot between different reasons for joining the program, and it was much higher in some conditions. Again, that's been useful in helping the NHS understand where whole genome sequencing is most useful early. But it also tells us how much more work there is to do. And one of the things which we're still working to improve and accelerate is what is an increasing number of diagnoses that now can reach families from a research finding. So the research component of the program, not just the knowledge we have today, allowing diagnoses for people who join the program or have a whole genome test, but also the researchers who can find new diagnoses and pass those back to families, or perhaps identify opportunities for further research studies, maybe even treatment trials that they might want to join. And so I think the final thing to say, just from a sort of a step back perspective, is I think a lot of what the 100,000 Genomes project was about was providing evidence, but also about that could inform future NHS commissioning. So much of that has come through the learning through the program. We didn't understand a lot of the problems that we'd encounter along the way. I don't think we understood, for example, the complexity of sort of really tightly linking research with clinical care, some of the making sure there's time for the right consent conversations to happen. And also the importance right from the beginning of the patient voice in guiding us, and many of the things that changed the most from the beginning to the where we are with the 100,000 Genomes project have been led by voices of the participants. So that tells you a little bit about about the 100,000 Genomes project and how it's got on. Sasha, from the perspective of a clinician involved in the program, tell us a little bit about your experiences and reflections.
It was really interesting for you to reflect on how things are so different for you, looking back at 2015 and then thinking about now. And I think that as a clinician, and lots of clinicians, that's probably one of the big things that I could say as well, is that actually where we were when this all started, and it felt so overwhelming, so complicated, and where we are now feels like a huge journey. And so I think that some of those feelings really were about being so overwhelmed, and how was this actually going to be possible? But some of the really positive things that I think as a genetic counsellor that came out of that was that kind of real spotlight of the importance of what we do, the importance of being able to take somebody on a journey and find a diagnosis, or how you treat them while you're finding a diagnosis. So it really helped other areas of the NHS, I guess, and the public see the importance of genetics and of genomic medicine and what impact that can have on the lives of our patients. It shed light on what we do as genetic counsellors, and how complex that is, and how other clinicians might need to learn about the way that we work, and how we learned from patients and developed a way of doing this very new way of genetic testing. And I think one of the really important things was this conversation that it opened up about the ethical way in which we practice, the way that we listen to patients, the way that we deliver results, because they were delivered through different channels by different professionals. So I think that, one of the major achievements was kind of opening that conversation and fostering that collaboration between people who work outside of genomics, and that can only continue going forward. And we hope that we will keep kind of learning those lessons, so that that model really that we've started to build about how we connect kind of research and clinical care together really continues to kind of benefit our patients, really, and the public in general.
I like that, the use of the word conversation. And one of the things that I really enjoyed being part of at Genomics England, and actually not generally being part of rather than someone who's been able to drive it, is how we develop that genuine dialogue where one doesn't come in, it's not communication, it is conversation. And I think that's one of the things I've really enjoyed, as I mentioned, with our participant panel that Rebecca's part of, but also more broadly in a number of different settings, with public, with experts, etc. Rebecca, it'd be really interesting to hear your perspective as a participant in the programme.
Yes, overall, the project has had a fantastic kind of impact on patient lives. It was a bold project, as you said, Sasha, right at the start, remembering back. And I think Sir Mark Caulfield, the former chief scientist, described the project as building a plane at the same time as trying to pilot the plane. And it kind of very much felt like that right at the start. But it gave, 1 in 4 rare disease patients who were part of that project a result. It gave them a chance to have access to a different treatment or a different care pathway. And it gave answers to a mystery that family was holding, which is incredibly powerful. For the others, like me, I haven't received a result from the 100,000 Genome Project yet. It gave us hope, because now our data is in the National Research Library, which is a fantastic resource, an absolute world-leading resource, where we hope that researchers, or through Reanalysis, we will get results eventually, a year, 5, 10 years down the line, as science kind of catches up with our kind of conditions. So it's been twofold, really, because, the 100,000 Genome Project participants many have actually benefited and felt that impact. But wider than that, the NHS patients now have impacted by, if you like, us going first. So the participants who joined the project really were the leaders here. They enabled, because their data is in the research library, because you've answered all of those questions, Richard, the Genomic Medicine Service was able to establish itself and is now starting to deliver results for other NHS patients who are facing those mysteries or facing those questions about their conditions. So it has a personal impact and absolute transformational impact for the wider patient population.
Thank you. I think that the sort of the bold vision and the Pathfinder, and I think that's one of the things that's really striking about sort of many of our participants. And I think our participants panel often talk about it, but that sense of being pioneers is something that people have to, I think you have grasped it and understood it and wanted to be part of that, but it's a bold step, not just for a program, but for individuals. And that's true for, I think, also for many of the clinicians involved and scientists. It's required boldness from lots of people. So I guess thinking a little bit about where the 100,000 Genomes project sort of led us and sort of towards some of the changes that have come from it. Sarah, can you tell us about sort of where we are now in terms of the NHS Genomic Medicine Service, some of the changes and so on?
Wow, that's a big question. So I think the changes compared to the 100,000 Genomes project are that mainstream clinicians and specialist clinicians are now being expected to be fully aware of the tests that they can order, because they've now been centrally commissioned. So rather than a patient living in a postcode where their local commissioners hadn't said to their local genetics service, yes, you can do that test. Now, potentially every patient that needs a genetic test, despite their postcode, has access to that genetic test as long as they meet the referral criteria. But that long chain of patients asking their clinicians, or clinicians sort of working out that their patients need that test, that starts with educating the clinicians and actually, I think, more importantly, as importantly, patients being aware of the possibility that they might have a genetic condition. And I think that's where the focus partly was in the 100,000 Genomes project. But the number of clinicians who are now able to order the test has become, I mean, it must have increased tenfold, if not more, Richard, I'm guessing. And so we have a lot of education still to do to enable those clinicians to start to understand which tests they can order and how to access them. So that's the access side of it. Then the reality is that, a lot of clinicians are very, very time limited, especially after COVID, and that's been a huge challenge for the Genomic Medicine Service. And so in order to actually take consent for the test and really fully inform the patient, the clinicians have to be very confident in themselves that they know exactly what the patient needs to know, and they know partly what the clinical side of things is, and partly what the National Genomics Research Library side of things is. And so a sticking point has been that clinicians haven't felt that they've had enough time in their normal clinic slots to actually be able to do all of that talking and answer the questions that come back at you, because there are a lot of questions that come back at you when you start to talk about the National Genomics Research Library and trio genomes and everything. So I think time carved out in mainstream medicine is going to be really important, and we're working to look at that pathway as well. The testing itself, the pathway for testing at GLHs, so at the genomic laboratory hubs, or at Illumina, who are doing the whole genome sequencing, is gradually building up to be at capacity. We're not at capacity yet, but we do have a lot of scientists that we need to train in order to interpret these much bigger gene panels and indeed whole genomes. So we're catching up on that too. The scientists in the NHS are up for the challenge, but there aren't enough of them, and they really, really are keen to get better equipped to actually do the new interpretation and reporting side of things. And then finally, clearly, we need to be able to support people when they get results back to the patients, or if there is no result from that test, we have to be able to accommodate those clinicians who are able to give that result in a really well-informed way, and those clinicians that want to refer to clinical genetics or a genetic counsellor and say, please help me, I don't really know how to do this. So the workforce really needs to be prepared and primed and taught about how to actually really embrace this whole a totally new way of working, really, when you think about maybe a paediatrician who's never ordered a test before now being able to order a genome. I think that's a snapshot of the beginning to the end. Huge numbers of challenges, huge amounts of people retraining, upskilling, differently working, all with the aim of actually making that diagnosis much earlier in the patient journey and giving the appropriate support to that patient. I think I should probably stop talking.
It's really nice, and I guess one of the big themes there is about giving the right support to clinicians to be confident and able to have those conversations, not just in testing but also in research settings. Sasha, I don't know whether you've got any reflections on that and how we go about that, what the challenge is.
Yeah, it is a really big challenge, because I think those tenets of what Sarah was talking about in how you talk to a patient, what you might know about the research area, the clinical area, all of that is genetics and genetic counselling. And so it really does shed a light on just how complex the process of genetic counselling is, just how much of a person's life, well-being, future choices, just how much actually goes into that conversation. So, it would be wonderful if there was a genetic counsellor at the point of testing for everybody who needs it, because that really is the collection of skills that Sarah's describing. So I think that is a really big challenge for us, is how do we have more genetic counsellors, because there are some of us, but there are not nearly enough for the amount of work that we want to be doing. But also, how are we meaningfully having education, having ongoing professional development, having support for clinicians who work in the mainstream, who want to be able to practice this tool of genetic counselling with the patients that they meet in front of them. So a big challenge, and something that I think is good, because it's provided a challenge to genetic counsellors to be part of that, and to be involved in that.
And I guess, Rebecca, from a sort of a patient participant perspective, thinking about how to make sure that that there's sort of equity in terms of the experience, and it's not dependent on where you are or who you meet, that you get the right information that you need.
No, absolutely. And we heard throughout the 100,000 project, we heard an array of experiences, some great, some really not so great, depending on the area that the person was in, depending on the rare disease type or the cancer type. It was sometimes really distressing to hear that patients have had to go through what they had to go through. And people also just not understanding what the 100,000 Genome Project was, that it's, as you said, Richard, right at the start, that it was kind of linking clinical and research, but people just saw this as clinical and not the research. So we're left with a no, but without the hope, that they weren't aware that they were actually still in the National Genomic Research Library, and there was still further analysis happening on their data. And that's such a powerful message to kind of lose as well. So I absolutely echo what Sarah and Sasha have said. That only can change with training and better resource and kind of better understanding of what the patient needs, because it's not one size fits all as well, that different patients at different points of their journey need different access to different information, to different support groups, and time. Some people just need to go away and think about it, then come back and ask more questions. They feel quite overwhelmed. Some people prefer to read, other people prefer to chat. So how that patient is and responding to their needs as well as their condition. So seeing the patient as well as what they are being treated for. So I very much hope that we can learn those lessons from the 100,000 Genome Project as well, going forward to the GMS.
Thank you. And then I guess oh, Sarah, go for it.
I was just going to say, in North America, there are a lot of guidelines that have been written for specialist bodies like cardiologists, ophthalmologists, where genetic testing is really an integral part of some particular care pathways. And in most of those professional body recommendations, it says you should only order genetic testing if you have expertise and time. So I think we just have to recognise that there are many people whose heart is totally in the right place and would love to have the time to have that proper conversation with the patient. And they may have done a PhD in genetics or whoever they are, they might, have a Nobel Prize, but if they don't have the right amount of time, they are failing the patient to actually be able to go into the questions that the patient has. And some of the worst cases that I've picked up in terms of patients being unprepared for the answers that came back to them have been because either the clinician didn't have the experience or the time to actually tell them what could come out of that test. And so I think it might be heroic to think that it's great that we can all get through, a quick consent in 5 minutes so that our numbers go up. And, what's the worst that can happen? But the worst that can happen is that people are left with diagnoses that they had no idea about, or that they don't understand the test and they really, really feel unsupported. So it does give us scope. I think some of those professional guidelines are really on the money, actually, and we should think about that in this country.
Yeah, and I guess it's that challenge of making sure that the bottom is that people need to understand what it is that they're signing up for, and whether that's a conversation, whether that's information in another way. That's the basic requirement.
Absolutely. I also think that there are smarter ways of going around it. I mean, if we could certainly, I don't know, we're brainstorming now, we could certainly have, many more resources that were, animated or just interesting to watch, to explain to patients in many different, levels and languages. But I think we do need much more centralisation of being able to give people information as a support to a conversation that's unique to them, because it's never going to be, as Rebecca said, one size fits all.
Absolutely. And I guess on that, sort of from a different perspective, that sort of thinking a bit more about things that we can do to improve in the future, it would sort of be interesting, Sasha, to hear some of your thoughts on what other aspects of diversity, in terms of diversity of background and in terms of opportunity, etc., that we need to make sure that we're doing better on, to make sure that we actually deliver sort of an equal service for everyone.
Yeah, I think one of the big challenges is that I guess the hope and the dream of rolling out technology in this way and services in this way is that equity is achieved because it's an equitable choice that you're making so that everybody has access to this. But we're laying this over systems of inequality that already exist. And so it's about being intentional about how are we going to do this that frog leaps over those things, because changing systems is going to be a really hard thing to do. I think one of the really practical things is about engaging people in the conversation and bringing the conversation to populations, to certain diverse groups, because as Rebecca pointed out, this feeling of being part of something, this feeling of contributing to ways that will help you or help others is just a human need that everyone has. And so being able to raise awareness, but also to help everyone understand about the benefits that they might have and that they might be sharing with other people, I think will be the same across kind of all cultures and all groups. But it's about that access. We used the word before, conversation. It's about access to that conversation, and where are we having those? Are we engaging in the right way as us with our desires, rather than expecting people to kind of find us and find the information? Sarah spoke about, having things in more interesting formats and in different ways that help people access kind of the information. But there is also something about us behaving differently and being in different spaces and being in different places to enable people to have those conversations. Ooh.
And I guess one of the, I'm just looking in the chat and also just thinking about the other areas that we might explore. Rebecca, one of the questions that's come up in the chat is about how patient organisations might engage with what's going on here, including on some of the questions Sasha's just raised. Tell us about how people can get involved.
So the new Genomic Medicine Service hubs, I think there's how many? 7? You have to correct me. And they will have patient and participant panels. So that's a great way to get involved, and that those plans are being developed now. So it's exactly the right time to get involved. And that will help ensure that that service is reflective of those community needs as well. So it's each hub covers a certain geography, such as east of England or the northwest. So patients can and patient groups can really get involved there and have a voice there. And then going up a level, then there is the National Participant Forum, where all of the GMS kind of patient groups come together, or their chairs come together, and then you can start learning about best practice as well. So again, what we found last time is that, you know, one region would deliver a result in another way and another region would deliver a result in another way, and neither of it got quite right. But if you perhaps put them together and kind of shared that best practice, then you may have something fantastic. So that's a forum to get together and share ideas as well. So there are lots of opportunities for patient groups to get involved and have a voice locally.
Thank you. And another theme that I think we touched on while we've been chatting, and has again come up in the chat, is about sort of, I guess, this theme of what patients can expect in the future, about the sort of the potential future hope for, if I don't find an answer, whether it's through the 100,000 Genomes project now or through my clinical test now, what can I expect? Sarah, I don't know whether from a sort of clinician perspective, you can say a bit about well, that sort of tension, and also also what we can say to families and patients.
So I think, Richard, I might let you speak about the reanalysis from the 100,000 Genomes project, because I'll leave that one to your expertise. I think from the perspective of the Genomic Medicine Service, we are setting up our analysis pipelines to be able to start to reanalyze. As they start, this is massively caveated. We want to be able to automate the reanalysis of any of the sequencing that we do, rather than having to wait until a clinician comes back and says, oh, could you have another look? Or a patient says, I really want to know, you know, has it changed in the last 2 years? So actually our lead bioinformatician in the East Genomics Laboratory Hub is amazing, and he's developed some software that does automate that reanalysis, and I think he's sharing that with, certainly it's open source software, but that's the kind of thing in the future that's going to make this standard of care rather than an exception. If you've already had a large genetic test as a patient and no answer was forthcoming, I think if you haven't had a conversation about that negative result from the person that actually gave you that result, and further conversations about what more could be done, then I would ask to go back and see that consultant or that clinician, just a conversation about, well, is there anything else that can be done? Is there anything you can do now that you couldn't do 2 years ago? And I think that may I, just because I know we haven't got much time left, but I also think that the biggest point that I want to make is that the next frontier is actually not just being able to give people diagnoses, but being able to make sure that we start lobbying for access to treatments for those diagnoses, because so many times we think we're amazing that we've given somebody a diagnosis, and the next question completely correctly from that patient or the parent is, right, what's the treatment? And we kind of go, well, hang on, I've just told you that. Okay, right, I'm in your wavelength now. Of course you want to know what's next. And so the more patients we diagnose, again, we're going to start letting people down if we haven't started lobbying for rare disease treatments to be higher up the agenda of the NHS and of the country. So I think reanalysis is on the horizon. Richard, have a quick chat about that from your perspective. It's going to be a reality probably in the next year for the Genomic Medicine Service. But our focus is also on making sure that those that get diagnoses actually then move along the treatment pathway and don't just end up with a diagnosis that doesn't really help them particularly, apart from to stop them being investigated.
Yeah, so I guess from 100,000 genomes perspective, we think about the ongoing search for new answers, whether that's diagnosis or potential treatment or trials or whatever, in two ways. One of them is because where people have signed up to the research offer. That means that there are researchers working to look for diagnoses, but also potentially trials or studies that they might be eligible for. And that ability to recontact via the clinical team and say, either we found something new that the NHS lab would have validated, or this is a potential future study that you might want to join, it is there. And that goes on. And that's what membership of this National Genomic Research Library means. And people who join that through the Genomic Medicine Service will have exactly that same benefit and experience. And then separate from that as well, there is the ability to routinely reanalyze. And that's one of the things that we at Genomics England are working with NHS England to work out two things. First of all, how do we do that for the benefit of 100,000 genomes participants themselves, but also, just as through the first phase of the project, that generated evidence to inform what happens in standard clinical care going forward. How do we develop the knowledge that lets us know how we should be doing this, what the best way of doing this in general is? Is it looking again at the information every year, every 18 months, whatever? So it's a sort of a two-tier thing. Either way, from a participant perspective, that would involve being recontacted by the clinical team if something relevant is found. Just thinking of looking at time, I wonder whether we've just got a bit of time, maybe for Rebecca, your sort of thoughts on sort of where we are in terms of like the longer terms of hope and future from a participant perspective of what we might expect from genomics in the next few years.
I think, the potential, as we have found and as we have seen over the change and the transformation over the last 5 years, has been fantastic. Who knows what the next 5, 10, 15 years will bring. I think Genomics England has set a good course, that it's embedded patient voice right at the very heart of its organisation. We were formed back in 2016, the same year as the Generation Genome report was published, and we've been involved ever since in how Genomics England designs its services and holds our data and who has access to our data. And that's absolutely essential in building trust, because without trust, we cannot continue to build a genomic medicine service. Trust and progress goes hand in hand. Sue talked about, the genomic dream and going forward and kind of realizing the potential of the genome and transforming patient care. But we can only do that if we take society with us, if we take patients and participants with us. So ensuring that their voice is always heard, that we're responsive to need, and we're getting patients involved early, right at the very start of the design, and we're listening to them and listening to changing views, because views will change between sort of now and the next 20 years, and the changing needs of society too. So I hope that, we continue to listen to the patient voice, because that really is the most critical voice in building trust in genomics.
Thank you. That is a wonderful note to end on. Rebecca, Sasha, Sarah, thank you very much for joining me. I've really enjoyed our conversation. And thanks to everyone for listening and for your questions.
Yeah, thank you. Thank you so much, Richard. Thank you everyone for a very fascinating discussion. And please do head over to the networking event now on the Remo platform. I've put the link in the chat. You can pick up the discussions further, or if you're not in a talking kind of mood, head over to the poster exhibition and have a look there. Or if you want to chat with some of our exhibitors in the exhibit hall, that's there too for you. So whatever mood you're in, please keep engaging. And thank you very much to our panelists for a really interesting session on genomics. And there's a lot of work to do, but a lot of progress that's been made. Thank you, everyone.